Okay, everyone, our next speaker is Sarah Furness. Natalie Wu also participated in putting this presentation together. These are two ICU nurses in our cardiac critical care unit. Natalie couldn't be here today, so Sarah's presenting on their behalf.
Is it on? Coarctation of the aorta is defined as discrete narrowing of the aorta, resulting in obstruction of blood flow. It generally results in left ventricular pressure overload. The most common location of the coarts is distal to the left subclavian artery, as demonstrated in the picture there. And it is approximately 4 in 10,000 births and comprises 6 to 8 of all congenital heart diseases. It is commonly associated with other cardiac anomalies. So complex cohorts are cohorts that are in conjunction with other cardiac defects, and the complex cohorts are usually in the presence of a bicuspid aortic valve, can be found in transposition of the great arteries, left-sided obstructive lesions such as Schoen's complex or hypoplastic left heart, ASDs, VSDs, and they're also associated with genetic syndromes. With these three syndromes, with Turner's, 35% of people who have Turner's are affected with a coarctation. So it is part of the investigation when a patient is found to have Turner's. So causes of coarctation of the aorta, there's no known sort of cause, but there's two theories that have been presented. The ductus tissue therapy theory, when ductal tissue is incorporated into the aortic wall during development, and when after birth the duct is no longer needed, constricting part of the aorta is constricted, bringing the isthmus of the aorta in and constricting it. It causes localized stenosis, so the shelf sort of appearance of a cohort. And then there's the hemodynamic theory, which is the failure of the isthmus between this left subclavian artery and the ductus to dilate post-transition from fetal circulation. And that is affected by the certain cardiac defects that I mentioned previously. So cohorts can affect people across their lifespan, and they present differently depending on, I guess, the extent of the cohort, and they present differently depending on how old they are. So we've sort of separated how different age groups present. In infants or neonates, immediately after birth, if the duct is present and is providing blood flow to the lower half of the body, then there may be no symptoms apparent immediately after birth. If it is a severe cohort or a long transverse hypoplastic arch with the cohort, it'll be apparent a little bit sooner. Post the ductal closure, so usually once these babies have gone home, the main reasons that they're brought in is decreased feeding responses, and they're found to have absent or weak femoral pulses, and then metabolic acidosis, myocardial depression, and lower body hypoperfusion. So renal and mesenteric arteries are compromised, which can lead to kidney failure and or neck, irritability, pallor, diaphoresis, and dyspnea, and a murmur may be audible. It's most commonly a systolic murmur, and it's either the blood going through the small area of the cohort or through the closing duct. They may fail the newborn pulse oximetry screen when the duct is still open. So I tried to find a picture of a baby in cardiac shock, but I just found this picture of a baby who looks shocked, so I put it in. So the treatment of a critical cohort in a newborn is an emergency, and in order to ensure survival, the duct needs to be opened or supported and stabilized. So prostaglandin infusions are started to support that. The focus is on stabilization and support of the infant, and then a surgical repair as soon as is feasible. Often these babies come in pretty sick if they have been being watched for a little while. So clinical presentation in older children and in adults, so it's not a critical coarctation. They might be asymptomatic with an incidental finding. In the literature, it seemed to be the presenting symptom was systemic hypertension. So investigation of hypertension in older children and adults was one of the main reasons that cohorts that were asymptomatic cohorts were found. There can be a murmur present, is typically systolic murmur that radiates to the back. And there's an arm and leg blood pressure gradient of greater than 20 millimeters of mercury. They may have hypertension-related headaches, lower limb claudication, which is usually exercise-induced, and collateralization. So if the older child or adult has formed collaterals, the symptoms may be minimized by the presence of collaterals. In order to diagnose, there's many ways to investigate it. The ECG may be normal depending on the degree of heart suppression or failure or hypertrophy. It's just along the lines. They may have right ventricular hypertrophy, T-wave inversion, left ventricular hypertrophy, which is seen in a progressive disease as a result of the systemic hypertension from the left ventricular outflow tract obstruction. So I've yet to see a cohort diagnosed by X-ray because we generally deal with infants at sick kids. So the X-rays tend to be non-specific. In adults, the film may show an indentation of the aorta, which is called the figure of 3 sign. And it suggests narrowing at the descending aorta of the level of the coarctation and dilation of the aorta pre and post the stricture. Bilateral inferior rib notching, so these little bumps that are in the ribs, can also be seen. This is in older children and maybe adults, in the 3rd to 8th ribs, suggesting the presence of dilated intercostal collateral arteries. The echocardiogram is much more specific than an X-ray in diagnosing a cohort. It can assess the severity of cohort and also identify any of the other associated cardiac defects. It is, however, difficult to determine a cohort in fetal echoes, a primary cohort. Usually the ones that are found or primary cohorts are in the presence of other cardiac defects. CT is also used. It's useful in patients with suboptimal arch imaging. Adults and older children or patients with poor windows can get better imaging with a CT. They are able to evaluate with 2D and reconstructed 3D. So this is the 2D, and then this is a reconstructed 3D. It's a useful tool for re-imaging when there's a stent or other metal, because doesn't produce significant artifact with metal. And the drawbacks of a CT is there is a lot of radiation and there's potential for contrast reactions. MRI, if they're having difficulty establishing where the cohort is, or surgical planning, MRI is also an option for diagnostic imaging. If the cohort is more complex, it'll help with planning, and it is able to define and quantify the collateral vessels that may have formed related to the coarctation. Indications for treatment, a peak-to-peak gradient of over 20 millimeters of mercury pre and post the cohort. Lesser gradients will be considered for treatment when there's extensive collaterals because that will lessen the gradient. The presence of systemic hypertension, other cardiac defects, and left ventricular hypertrophy, or elevated left ventricular and diastolic pressure. There are a variety of treatment options, and there's different treatment options that are better for different types of cohorts and different setups. The surgical repair, transcatheter balloon angioplasty, transcatheter stent implantation. The surgical approach is the preferred method for infants and young children. There are a variety of techniques that they use to repair cohorts that have been established from the 1940s, and up until the mid-80s, it was the only available treatment for coarctation. The first type of repair that was done in 1944 by Dr. Crawford was the end-to-end anastomosis. It was basically cutting out the coarcted tissue and then sewing it back together. It had, because of the circumferential suture line, there was a high, over 50% recoarctation rate, possibly caused by the scarring close around the aorta. A benefit of it is that by avoiding the prosthetic material or by not implanting anything, it allows for growth. So it can be used in infants and children. The most popular method currently used is the extended end-to-end anastomosis. It's a modified end-to-end, the broader longitudinal incision. It is less prone to restenosis, and it allows for our enlargement of the transverse aorta in children with smaller hypoplastic transverse arches. And it also allows for growth by avoiding the prosthetic material. It is less prone to the restenosis that was found in the classical end-to-end anastomosis, with only 4 to 11%. Patch augmentation is when the coarct tissue is cut out and the arch is augmented by prosthetic patch. It can be applied to longer segments of coarctation, and it avoids the circumferential suture line that was found with the end-to-end anastomosis. However, with longer term outcomes, there is a recoarctation rate of 15 to 20%, but the main reason this method has fallen out of favor is because of the aneurysm aneurysm occurrence rate between 18 and 51%. Lastly, the subclavian flap aortoplasty is when the left subclavian artery is divided, folded down, and used as autologous tissue to augment the aorta. It also avoids the circumferential suture, but is associated with decreased length and muscle mass in the left arm because of the reduced flow to the arm related to subclavian steel. In adults, another method is the interpositional graft. It's useful in repairing recoarctations or aneurysms in the arch, but is primarily used in adults as the graft doesn't enable children to grow and would require a reoperation. There's catheter base interventions that can be used to optimize and repair coarctations. The balloon angioplasty, it causes tears in the intima media, which is the tissue within the aorta, and causes remodeling of the aorta post-balloon. So they put a balloon in, stretch it out, and it enables the blood to flow. It is a preferred option in older children and doing repairs with recoarctations. It's not primarily used in infants because of the higher recoarctation. It has a higher recoarctation results than surgery. Because of the large catheters that are required, there's also, and the vessels being small, there is a higher chance of vascular injury. But it's recommended to use in stabilized infants, such as the critical cohort that comes in and just needs to be stabilized. It can provide blood flow if the duct is not able to, it can quickly provide blood flow if the duct is not able to be opened, and then can be surgically repaired after, as surgery is the optimal way of treating cohort in infants. Transcatheter stent implantation is the preferred treatment of native and recurrent cohorts in older children, adolescents, and adults. It's not used in younger patients as they would likely need reoperation or dilation of the stent, and it has been shown to have less acute complications. As with the previous catheter, the balloon catheter, it's not used in younger children because of the risk of vascular injury as well. Long-term outcomes, coarctation, they do have a good prognosis for normal growth and development when successful. Primary repair is done in childhood before the age of 9. Neonatal mortality post-repair is approximately 3% and has much improved with certain medical surgical advances, and previously was a 30% mortality. 15% have a mortality of 15%, mean age 38, due to the risk of coronary artery disease, heart failure, cerebrovascular accidents, and ruptured aortic aneurysms. Potential complications and risks. So with a surgical repair, additional surgery is required in 11% of the population related to residual coarctation if a balloon or a surgery isn't giving the adequate flow, recurrent coarctation, coronary artery disease, and progressive valvular disease, as in the previous talk about valvular disease can have nasty effects. Many of the children with cohorts have a bicuspid aortic valve and are affected by this. Systemic arterial hypertension treatment is required in a quarter or 25% of all patients with a cohort. And that's my talk on cohorts. Any questions?
Okay, thank you, Sarah. That was a really excellent presentation on coarctation. It was interesting to hear about the theories of the ductal tissue theory and the hemodynamic theory, and also to hear you present about how there are differences across the lifespan, so from the newborn to the child or the adult, and just some of the things around the diagnostic testing, and with the newborn screening also being something that we've just started really more over the last probably 6 months to a year, and just the very varied ways that we repair these coarctations from stent placement, balloon dilatation, and the various surgical options. So thank you very much for sharing that.